Thank you very much, Mr. Chairman. Ladies and gentlemen, first of all, let me thank the organizing committee for inviting me to be here. It's really a pleasure. And as you see from the title, I've been asked to talk about the surgeon perspective in mitral therapy. Now, I'm a surgeon. I'm a cardiac surgeon working in San Raffaele University Hospital, you see here in this slide, which is in Milan. Probably this doesn't tell you very much. It's more interesting to know that this institution is the one where actually Alfieri is working and where the edge-to-edge technique was invented. So the first slide I would like to share with you is this one, because there are some things which you need to know. I mean, my perspective is somehow unique, I would say, because it is true I'm a cardiac surgeon, as I said, but I have the privilege of working in a high-volume repair center, because we do perform in our institution more than 450 mitral repair per year, and that is very important when you are talking about interventional procedures. I'm fighting with the microphone, but I will win, I'm sure. It'll just take a while. It's a hard battle, but okay, stay like that, good. I don't touch it. Yeah, if it stays here, I don't touch it. But if it falls down, I have to touch it. Otherwise, nobody's hearing me. Okay. So, as I said, it's interesting to talk about Mitraclip because indeed, I don't do Mitraclip. I don't do Mitraclip, but I'm very in favor of the Mitraclip procedure. In our institution, we do our clip our own. It means that the surgeon is performing the Mitraclip procedure. So I don't have. We do discuss the cases in a heart team context, but we have the technology, the know-how to perform Mitraclip in our operating room ourselves. So what we did is that we built up actually a rather referral center for Mitraclip. We've been performing more than 300 Mitraclip cases in the cardiac surgery operating room so far. And at the same time, we do perform, as I said, more than 450 mitral repair per year. And a very interesting point to me is that we introduced the edge-to-edge technique. So we do have a huge experience with this approach, which is, lasting for more than 20 years because the edge-to-edge technique was introduced in the 1991. So it's certainly more than 20 years we've been dealing with this technique. So this is actually our activity. You see here from 1991. Of course, we were performing mitral repair also before, but I'm pointing here 1991 because that is the time when the edge-to-edge technique was introduced. And you see in the blue lines are the overall number per year of mitral repair performed. You see that from the beginning of 2000, we are rather stable with about 450, 470 mitral valve repair per year. And the orange bar is the percentage of patients receiving a surgical edge-to-edge repair. You see that we had a peak at the beginning of the year 2000 with about 35% of the patients undergoing mitral valve repair having an edge-to-edge technique. And now we are stable with about 20% of the patients receiving this approach. So the first important point is that we do not repair mitral valve just performing the edge-to-edge technique. 80% of our patients, they do receive a conventional approach, artificial coronary resection, whatever you like, minimal invasive, and so on. And then 20% of those patients keep receiving an edge-to-edge technique. And I'll show you why we do that. Now, why this is important? Because basically, the Mitraclip is nothing else than the percutaneous performance of an edge-to-edge repair, but without a ring so far. And so, what we've been learning over the years about the surgical edge-to-edge technique, I think does have important implication also in the Mitraclip perspective. And what do we know about the edge-to-edge technique? It's interesting to hear that surgeons say that the edge-to-edge technique doesn't work. Well, it depends on how you do the technique, how much experience you have got in this field. It's absolutely the contrary what we do believe about that. And of course, we try to publish those data. Those data have been published, and those are complex repair. This is a Barlow disease with a severe bilateral prolapse. We have been operating hundreds of patients with an edge-to-edge repair combined with annuloplasty. And we are not talking about 12 months results, 3 years results. Here you see that those are very long-term results. And the freedom not from reoperation, we are not interested in freedom from reoperation. The freedom from echocardiographic recurrence of 3 or 4 plus mitral regurgitation at 14 years in barrel disease with bileaflet prolapse was higher than 83%, which in this setting is a very good result, particularly if you compare with the other results reported with conventional approaches in the literature. They are certainly not worse and probably better. What about anterior leaflet prolapse? Even in Tyrone David hands, those are the worst settings. You know, anterior leaflet prolapse is associated with a higher repair failure than even bileaflet prolapse. And here we were able to draw our curves up to 17 years, and the freedom from the same event, echocardiographic recurrence of MR, 3 plus or 4 plus, was higher than 80% at 17 years. And many patients were operated for commissural lesions, which is a kind of particular setting. You know, when you have A3, P3 prolapse or flail, or the commissural zone is involved, there are several techniques you can use. What we call a paracommissural edge-to-edge repair, which means closing, a relatively large portion of the valve in correspondence of the commissure. This is associated with excellent results, 96% at 11 years. So I don't think that the edge-to-edge, surgically speaking, is not working. I think it's an excellent technique, particularly if you do it, or better, exclusively if you do it with a concomitant annuloplasty. Because what does it happen if you don't use an annuloplasty? And this is the interesting point. We assessed all those patients as well, because at the beginning of our experience, we had this same question. Do we need to put a ring when we stitch the leaflet together? So in a certain number of patients, for instance, in degenerative mitral regurgitation, we did not use at the beginning a concomitant annuloplasty. We simply stitched the leaflet together, either because the annulus was somehow calcified, or in many instances because intentionally the ring was avoided to avoid the risk of stenosis, or because we thought it was not dilated, and so on. And what we saw following those patients, and you see that here, the long-term results are very, very long-term. This was published in Circulation last year, is that at the beginning, up to 4 years, 5 years, you still have a freedom from recurrent severe MR, which is about 80%. But when you go on with the follow-up, at 12 years here, the freedom from this event is just 39%, which means that more than 60% of the patients do develop 3 or 4 plus MR, do require reoperation. So the results in the ringless edge-to-edge repair in the degenerative setting are not satisfactory. One point which is very important to make is in this degenerative setting, in most of the papers I show you, one predictor was always identified as an important risk factor for failure of the repair, which is a suboptimal initial outcome, which means patients who were discharged with residual mitral regurgitation 2 plus, usually more than mild. Those were the patients who mostly developed severe mitral regurgitation and follow-up. So you need, of course, an initial optimal outcome to have a good long-term result. Now, the Mitraclip system, indeed, does have those 2 weak points. It does not include a concomitant annuloplasty, and it is associated with a significant rate of residual or recurrent mitral regurgitation. Is this important from a clinical point of view? It is important. This is just published paper where we asked ourselves in Journal of Thoracic Cardiovascular Surgery, what is a good result after transcatheter mitral valve repair? You all know that as surgeons, if you do mitral repair in theater, and at the end of the procedure, your echocardiographer is telling you by transesophageal echo, you've got 2 plus moderate residual mitral regurgitation, you don't consider that a success. That's not a procedural success. You go back and you fix the valve, and then you come out of theater. Now, so far, before the new MVARC definitions, for the Mitraclip system, a peri-procedural success was defined as a residual MR equal or less than 2 plus. So that means that 2 plus is not a good result in surgery, but if you do with Mitraclip, 2 plus is a peri-procedural success, which is somehow, ambiguous. So what we ask ourselves, is 2 plus residual MR after Mitraclip really, important or not? And you see here the blue column and the orange or brown one. Those are patients with residual 2 plus mitral regurgitation after Mitraclip, and those are patients with optimal result, which means no or mild MR. And you see that at follow-up there is a completely different incidence in terms of a higher rate of cardiac death and also progression to 3 or 4 plus mitral regurgitation. So it is matter, it does matter, it is important. So the question with Mitraclip from a general perspective is not safety. Mitraclip is certainly safe. There's no doubt about that. Out of 300 patients, we had to convert one single patient to surgery. So Mitraclip is very safe. The problem with Mitraclip is effectiveness. Is Mitraclip effective, really? Now, effectiveness of a procedure depends on where we set the bar. And since there are several discussions around and different arguments and so on, I think that when we are talking about degenerative mitral regurgitation, there is no doubt that the bar has to be set very high. Why? Because it is true, also in mitral valve surgery, mitral repair still represents somehow a lottery. It depends on the experience of the center, of the surgeon, the volume of the cases you are performing, and so on. But you should not ask a center performing 5 mitral repairs per year to operate on asymptomatic patients. That should not be the case. You have to deal with referral center, excellent centers for this type of surgery, and if you deal with them, you see all over the world, in most of the countries, that there are some of them performing very, very well. And you can get nowadays a repair rate which is approaching 100%. And with a hospital mortality which is well below 1%. You see here, we had a look at our data in 2006. Now I don't find my arrow. Here it is. You see De Bonis here. And hospital mortality was 0.27%. But many other colleagues, you see, and centers report a hospital mortality which is in elective cases below 1%. And what about durability? I can provide you, many, many data. These are just the data published in Circulation by Tyler and David. You see that the freedom from recurrent MR in the overall series was 99% at 1 year, 90% at 20 years, the freedom from recurrent moderate or more than moderate mitral regurgitation. Now, what about Mitraclip? These are real world. This is the ACCESS Europe registry involving mainly functional mitral regurgitation patients, but also degenerative patients. If we look at the degenerative subgroup, you see here, those are the immediate results of a Mitraclip. You have, at discharge, 11% of the patients with residual 3 or 4 plus mitral regurgitation. This is not a trial, this is really a registry. And this percentage comes up to 25% at 12 years. Now, if you consider also the patients with 2 plus mitral regurgitation, so 2, 3, and 4 plus, you get at 1 year in degenerative mitral regurgitation more than 65% of the patients with this type of outcome. And this is our own experience in San Raffaele. You see this on the left side is the residual MR at hospital discharge, and here you have the follow-up at 2 years in patients with degenerative mitral regurgitation. The freedom from 3 or 4 plus mitral regurgitation was 76%, which means that 25% of the patients had at 2 years 3 or 4 plus mitral regurgitation. Now, I think that in degenerative setting, this is not acceptable if the patient, of course, is a surgical candidate. It's perfect if, according to the American guidelines, the patient is inoperable. And I think we can agree about that, but I think it needs to be somehow emphasized, because also in my institution, sometimes I get patients from the outpatient clinic, and they come to me asking for a Mitraclip, and they have a P2 prolapse, they are 65 years old, and I start struggling to explain them why you should open the chest and do surgery rather than put in a clip, and in 1 hour everything is finished. And you need to show all these to make them convinced that that is the good thing to do. What about secondary mitral regurgitation? Here I agree with most of our of the speakers before. Of course, we can set the bar a bit lower. Why? Because in secondary mitral regurgitation, neutralization of the disease is not the target. This is a ventricular problem, so the objective of treatment is to correct or to reduce MR, to improve quality of life, symptoms, obtain reverse remodeling. What about survival? We do not have randomized data. Something is coming up, but we were really not able so far to clearly show an improvement in terms of survival. But again, if we are talking about Mitraclip, this is San Raffaele on the right side. This is the ACCESS Europe registry, and again you get that 20% of the patients in secondary MR do have at 1 year 3 or 4 plus residual recurrent mitral regurgitation, about 40% of them moderate 2 plus MR. And that is the reason why it was rather interesting to read in the 4 years results of the Everest trial this sentence, which stated that in the subset of patients with functional mitral regurgitation, those who had a procedural success, which means a good initial outcome with the Mitraclip therapy, those patients had those results stable at 4 years. So actually, they remain stable, those data. Of course, it is emphasized that further studies are necessary, and that is the reason why we did another study, I'll show you. But if you look at the table of the Everest trial, actually, this statement is based on a relatively small number of patients. You know, the surgical group included just 22 patients, and the Mitraclip group included just 44 patients. So what we did in our institution, and those data have been presented in Amsterdam at the last EACTS meeting, and they've been submitted for publication. We said, okay, we will take the best patients undergoing Mitraclip therapy in our institution. So we will not include patients with a residual mitral regurgitation 2 plus or 3 plus. We take the best one. So all those patients who had after Mitraclip therapy 0 or 1 plus residual mitral regurgitation. And let's see, since we are following them systematically, let's see what happens at 2, 3, 4 years. At the same time, we had a very good comparative group of patients with secondary MR, with excellent initial outcome, submitted to surgical edge-to-edge repair plus annuloplasty. So we could have a control group. So you see that the two groups here are rather similar. 85 were in the Mitraclip group, 58 in the surgical edge-to-edge. They have the same ejection fraction, 28%, and systolic diameter 67, 69, and systolic diameter, volume, pulmonary hypertension, degree of tricuspid regurgitation. Why is that possible? Why surgical patients are comparable to Mitraclip patients? For the simple reason that the surgical patients enrolled here, they were operated when Mitraclip was not available, before the year 2008 in our institution. Therefore, they were rather high surgical risk cases with very low ejection fraction. They did not have another choice. Mitraclip was not there, so they were operated. And at the end, they were rather comparable, therefore, with the current Mitraclip population. Now, the interesting point is that we took the best. So at discharge, you see hospital discharge, all patients had mild MR or no MR, you see. At 1 year, following those patients in our institution, 27% of them had already a progression to 2 plus or 3 plus MR. So there was a progression at 1 year. And then we start making a matched comparison between the follow-up, echocardiographic follow-up, at 1 year and 2 years, 1 year and 3 years, 1 year and 4 years. And you see here the outcome. 1 year and 2 years, you see that there is a significant increase in the degree of 2 or 3 plus MR. And if you compare 1 year and 3 years, this is even more evident. And if you compare 1 year and 4 years, still there is a significant increase. If you compare those patients, Mitraclip patients, with those admitted to surgical edge-to-edge plus annuloplasty, you see that the freedom from recurrent MR, 3 plus or 4 plus, is very different. And if you consider the 2 plus subgroup, this is very impressive. So we were not able in our institution to confirm the Everest findings, meaning that if Mitraclip therapy is initially successful, those were all patients with optimal outcome at the beginning. The results were sustained at 4 years. They were not sustained. Compared to Mitraclip therapy, our surgical approach provided higher efficacy at 4 years. Why is that important? Because then you have to decide on the single patient. You can do in a heart team context, you need to have your arguments and your data. And so when a patient like this, which is a true patient sent to us from south of Italy, you have to discuss about, you have to consider all the things I told you when you need to take your decision. So this is a patient who comes to you, is young, 46-year-old male, no coronary artery disease, a long history of congestive heart failure. In the last 3 years, he has got an increasing shortness of breath symptoms. He currently is in functional class 3B04. He had 3 pulmonary edema in the previous 6 months, and he has been having long-standing persistent atrial fibrillation for 18 months. They tried somewhere else also to do percutaneous ablation, which failed. This patient in the hospital, referring hospital, was considered just suitable for heart transplantation. Then he came to us, we did transesophageal echocardiography. You see he had a 28% ejection fraction. The endosteric diameter is huge, 75. Sphericity index is still 0.6. He had severe secondary MR. And a dilated tricuspid annulus with 2+ tricuspid regurgitation. So this is a patient with, you see here, severe secondary mitral regurgitation. There is a central regurgitant jet. The origin is in the central portion of the valve between A2 and P2. The coaptation depth is 1 centimeter. Tethering is not extreme, and there is a coaptation length between the two leaflets of more than 2 millimeters. So this is certainly a patient who is a potential candidate for Mitraclip. And you have to decide what to do: heart transplantation, Mitraclip, surgery. So Mitraclip could be an option. Probably one might say, Mitraclip is safe, that will be associated with a lower procedural risk compared to surgery. But of course, if you do Mitraclip in a patient who is 46 years old, certainly, first of all, you will not address atrial fibrillation, which in this case, to me, represents a therapeutic target, because the duration of AF is just 18 months, you can address it. You can treat also, you cannot, of course, address tricuspid regurgitation. And as I showed you, in our experience, it will be associated with a higher likelihood of residual recurrent mitral regurgitation with negative prognostic implication, negative effect on reversible ventricular remodeling. So if you don't want to, if you think it is too early for heart transplantation, you want to consider surgery, then you have these 3 operations here. The only thing you need to avoid is bed repair, and we can discuss for hours also about the trials published in the New England Journal of Medicine about that. I'm very happy to discuss about that if you want. You have to decide between replacement and repair, but this repair, if you want to do repair, you have to be confident that this is going to be somehow durable. So you have to avoid bed repair. Now this patient has got an important dilatation of the annulus of the mitral valve, so you can work on the annulus, decrease the size of the annulus and force the coaptation of the leaflet, which you cannot do if the annulus is not dilated. The tethering is not extreme. I showed you there is a symmetric tethering with a coaptation depth of 1 centimeter. The posterior leaflet angle is 30 degrees. The distal anterior leaflet angle is 17 degrees, so tethering is not extreme. And if you look at other predictors of failure of repair, there are no other predictors here in this patient. Even the inferior akinesia, dyskinesia is not here. Present systolic sphericity index is below 0.7. There is certainly a endosteric diameter which is concerning because it's 75. And first of all, the first thing I would like to tell you, I heard before about the cutoff and so on. 65 has been published by Robert Bion as the cutoff value to get reverse remodeling. In our experience with functional mitral regurgitation, the mean endosteric diameter was 72, and we've got reverse remodeling in 52% of the patients. So those are cutoffs which are not dogmatic. The interesting point is that this patient has got atrial fibrillation. If you are able to restore sinus rhythm, I think that you can get much more prominent reverse remodeling than you get just by performing mitral valve repair. Now, we have a surgical risk which is reasonable in our consideration. The patient has no comorbidities, is young, no renal failure, no pulmonary disease, no hepatic problems, and so on. The repair can be durable because the annulus is very dilated. There is no severe tethering. The coaptation depth is 1 centimeter. You can address by surgery secondary MR, tricuspid regurgitation, and atrial fibrillation as well. So we went for surgery. We put an undersized complete ring, a semi-rigid ring on tricuspid side as well. And we did a radiofrequency bipolar ablation of atrial fibrillation combined with cryothermia to perform properly the mitral line. And what we got at the beginning, immediately after surgery, and I hope this is working. It was working before. Usually it works when you try. It doesn't work at the podium. Let's see if it's different. It doesn't work.
Maybe we skip it for the sake of time.
Yeah, sorry. I'm sorry. No, doesn't matter. There was no MR. And the other important point is that you see here, it's very important there is no MR, but yet the most important point is this one. You see that the two leaflets are coapting for a very long surface of coaptation. They are not just touching each other, for 1 millimeter. They are really coapting very well, and the coaptation length was 9 millimeters in this patient. There was no tricuspid regurgitation. and the patient was in sinus freedom. He had discharged, he had already 40–45% ejection fraction. Now the discussion was very, intense, but I think we did a good job in this patient. He didn't receive heart transplantation, he didn't receive Mitraclip, he did conventional surgery 3 years after. He's in very good shape. Functional archives is very much improved. The reverse remodeling has been very important. There is no recurrent mitral regurgitation, no tricuspid regurgitation. Of course, if the same patient had many more comorbidities, inoperable, high surgical risk, and so on, very high, we would have gone for Mitraclip. And that is to emphasize once more, the fact that Mitraclip and surgery are complementary procedure. They need to target different population, not the same population at all. And that's what we try to emphasize once more in this position paper we published just a few months ago in the European Heart Journal on behalf of 2 working groups of the European Society of Cardiology. Now, 2 slides more. This is now, to me, what about the future? Well, the future is probably in this slide. This is one patient we did a few months ago. You see here there are 2 clips. It's a fluoroscopy. You see a lot of screws here. Those are the screw of the cardioband, which is a totally percutaneous direct annuloplasty. So in this patient, actually, we did a Mitraclip repair and a percutaneous cardioband. So this is a full percutaneous procedure, which is very similar, you see, to the surgical one. This is a surgical patient with a central double orifice repair and a trigon-to-trigon surgical ring. Now, if this is going to be much more durable than the results I showed you, I don't know. I hope so for the patients. Will this change my perspective, our perspective? I don't know. I know that there are no secrets that time does not reveal, so if we wait a bit longer, we will certainly be able to know that. Thank you very much for your attention.
Thank you very much.